Hello everyone, how are you? Hope everybody is okay and doing well with the preparation. So all of you who are online today have submitted the fees in MRCPI exam. Hello, I guess most of the students are not yet online. Let me introduce myself to you. I'm Dr. Asma, one of the co-hosts and also the lecturer of MRCPI. And I will be giving a free webinar on the topic of amenorrhea that will include primary and secondary amenorrhea causes, which usually comes in the exam and is sometimes a very hot favorite topic. The other thing is that we are starting this written course and this includes the preparation of whole of the MRCPI written exam. And we have divided this whole course in different modules, which includes different topics involving the early pregnancy module, the oncology module, the gynae module, and also different 13 module covering whole of the gynae and obstetrics, medical emergencies, medical maternal medicines, etc. So in all of the module lectures, what we will be doing is that we will be delivering out different lectures, including important parts of the summaries, which will be according to the Irish guidelines. And those topics which are not covered by the Irish guidelines will be covered from the Royal RCOG guidelines and also the American guidelines. So this helps students prepare better for attempting the single best answer questions that usually comes in exam. The thing is that after we are ending up with our module lectures, we will be starting with our recall sessions, and hope everybody is able to listen to me. So in the recall session, we will discuss about important recalls that comes in the exam. And then after that, and during the course period of time, we will give the support throughout till your exam, and also will give you different summaries of the guidelines, which are very important and which we think you should know before attempting for the exam. And moreover, you will be given different quizzes so that you can assess yourself before the recall session, so that you can better get prepared yourself when we come to that session. After you're done with the recall session, then we will give you a best of luck for your exam, and we'll see that whether you will be able to make it or not. And I assure you, this MRCPI written exam is not that much difficult as compared to the MRCOG exam. And most of the students go through it in their first attempt with good guidance. So if you think, all of you, that if you want to ask more questions related to our course, I welcome you all at the end of the session. The contact numbers will be shared with you so that if you need to address your queries, you can contact our team members and we'll let you know what our program will be throughout our written course for the exam. And this especially for the September exam. We will be starting our first session from 4th of June. So let's, I think most of the students have already joined in and would be joining in with time. And let's discuss our today's topic of amenorrhea, which is also a very important and interesting topic. And I welcome you all in my free webinar. So this topic is going to cover your primary amenorrhea and secondary amenorrhea. Let's just go through the important definition before we start with the important topic. So amenorrhea is actually the absence of the menses in a woman of reproductive age, and it can be primary or secondary. And secondary amenorrhea is the absence of periods for at least 3 months if the patient has previously had regular periods, and 6 months if she has previously had oligomenorrhea. In contrast, oligomenorrhea, infrequent periods with bleeds less than every 6 weeks, but at least one bleed in 6 months. So this comes in the definition of secondary amenorrhea. Once you get this scenario in your question or SPA, you're going to click for the topic of this amenorrhea. So these are the important causes you should all know, and I have divided this into the estrogen deficient type and the estrogen replete type. So you divide it into hypothalamic, pituitary, thyroid, adrenal, ovarian, uterine, and vaginal. Go from above, from your head, and then come down. The causes would be easily remembered in this way. So these are hypothalamic causes, including eating, exercise-induced, medication-induced amenorrhea, chronic illness, stress-induced amenorrhea, and Kalman syndrome. While the estrogen replete would be immaturity of the hypothalamic pituitary axis. Pituitary causes include hyperprolactinoma, prolactinomas, and craniopharyngiomas, and isolated gonadotrophin deficiency. While thyroid causes would be hyper and hyperthyroid, and adrenal causes would lead to the CAH and Cushing syndrome. Ovarian causes would be, in case of estrogen deficient, gonadal dysgenesis, that might include Turner syndrome and premature ovarian failure and polycystic ovarian syndrome. Now, uterine causes would be chemotherapy or irradiation that leads to the deficiency of estrogen and ultimately leads to amenorrhea. And in cases of the estrogen replete, this may be because of pregnancy, androgen insensitivity, uterine adhesions, Mullerian agenesis, cervical agenesis, and vaginal causes include imperforate hymen, vaginal agenesis, and even transvaginal septum. Now, looking at this table, it makes you very confused. It's a lot of, PDs and lots of differentials. And when you look at the scenario, how are you going to solve them? That's very easy to, when at the end of the lecture, let me just make it a slideshow. So I think this table will be visible to all of you now. So at the end of the lecture, you will be able to know that how you have to implement all these causes into the scenarios of primary and secondary amenorrhea. But looking at this, you'll feel confused that how will we remember? So this is an important topic. Yes, can you hear me now?
Dr. Asma, yeah,
yes,
you are
hello?
audible now. Yeah. But your voice, it missed out totally. So you can repeat the point. Thank you.
Okay, no problem. So this is an important table. So it shows lots of differential diagnosis relating to amenorrhea topic. And once you remember them, it will be still very difficult for you to solve your single best answer questions. So we will make it a little more easier, but before I will make it easier for you that how you have to apply in your scenarios, let's just go through one important topic from a very important talk, Ogram. I would like you all to see. Hope everybody is able to see this page of mine. So this table is of from the Ogram, and that's a beautiful OGRM. You don't need to go through it. In this beautiful Ogram, this is also a cause of primary amenorrhea. So all of the causes are written in a very, very easy language. So hypothalamus causes include weight loss, intensive exercise, idiopathic causes. Pituitary causes include hyperprolactinemia and hypopituitarism. And hypothalamic pituitary damage includes tumors. It may be because of head injury, cranial irradiation, and ovarian causes because of gonadal dysgenesis, primary ovarian failure. The uterine and outflow tract causes usually involves the Mullerian agenesis causes that also include imperforate hymen, transverse septum, and chromosomal problems like Turner syndrome, including androgen insensitivity syndrome and MRKH, which is not mentioned here, but this also comes in this heading. Now, systemic disorders, you need to bring all these headings in your mind. So the second most important thing is you need to know what actually the important thing according to the DD table, which I've just told you, differential table, you need to ask. So the highlighted area you see here while solving the question, you need to find out in SPA all these written or not, whether is there a problem in the eating habits, weight loss gain, stressful events, contraceptive history. Inquiry should be made about any developmental delays, especially breast and axillary pubic hair, and other symptoms like abdominal pain, headaches, visual disturbances, galactorrhea, hirsutism, and vasomotor symptoms. So, and any major systemic illness, past and ongoing. It also includes drug history, especially use of antipsychotics, anti-epileptic, cytotoxic agent, any recreational drugs like heroin, cocaine. This has to be noted with care. And family history is of very important because of timing of the menarche or premature menopause in mother, and sisters, if present, can also give valuable information in aiding diagnosis. Now here, by this memorizing this paragraph, you will come to know that how you have to take out different points or make a differential, make a diagnosis from your differential diagnosis, which has been given in this table. Okay, so you ask question. Now come to the examination point. Now this table is very important. Why this is important? Now this is going to tell you this table. So this is going to tell you about your further exclusion of criteria type of exclusion. It is also going to exclude DDs now. You will measure weight. So if the weight comes and height comes in a normal range, it will make BMI in a normal range. You will exclude the cause of hypothalamus maximum because it will take out stress related causes and other things which might be related with this part. Now you will see these came evidence of androgen access, and this is important not only in the terms of your OSCE point of view, but also in terms of your solving written SPA point of view. So this paragraph will let you know that how you have to exclude different DDs. So you have to see the eyes for visual field effect, and why we are doing this because of pituitary tumors. Now clinical thyroid status you should know, and it will be visible by thyroid swelling when you see the patient on examination. And if you find such findings in your scenario, then you'll be able to exclude that it's okay, now I'm not going to think about this as a cause of primary amenorrhea. Dysmorphic signs, if this is present or not, pubic and axillary hair stages, is it scanty or is it fully developed? So this is going to exclude whether she is coming in chromosomal problems or not, because this will click your mind and take you into the differential diagnosis of MRKH or CAIS. That means congenital adrenal androgen insensitivity syndrome. Now you'll see the breast Taylor staging. If that's okay, and she is having good hairs, and then still it's making keeping the diagnosis of genetic problems and also the woman with the normal uterus still in your mind. Now you'll see the galactorrhea, if it's present or not. No, it's not present, then prolactinoma, you're going to take out this option from your mind. Now come towards the systemic examination. CVS, abnormality present in Turner syndromes, you'll have to see because you'll see the murmurs. And in some time, Rokitansky syndrome, it is seen that there is a problem of cardiac murmurs in conduction defects like auditory hearing problems. So if these are not present, you will rule out maximum causes of in your mind like Turner's or MRKH. Now in the abdominal pelvis, you have to see of any lump, groin nodes or hernia. Why hernia and lump? Because these two things are relevant with congenital androgen insensitivity syndrome. Now you have to see external genitalia, and this is to see that is there any androgenizing or virilizing effects or not. And this virilization is very important in case of congenital adrenal hyperplasia. Then if you do not see such things, then any abnormality in positioning of the anus and the vagina, in the urethra, so this also helps you rule out different differentials, which you just discussed. Imperfect hymen or low tonsil vaginal septum, this will be seen by gently separating the labia during the inspection. So maximum information, you have seen it. Now this paragraph this also is very important figure. It's a stepwise approach to diagnose primary amenorrhea. So you'll ask in history and examination the questions which I've just shown you. You'll ask important questions. You'll see the important findings in the examination. Then you will go for pregnancy test. Then you will also do LH, FSH, estradiol levels, prolactin, TSH, and pelvic ultrasound. Here, if the pregnancy test is positive and patient is having amenorrhea, you do not see anything on the uterus, then go to exclude for ectopic pregnancy. Abnormal TSH levels, you'll have to order thyroid function test and treat thyroid disease. Now, if there is a history consistent with the prolactinomas and examination shows galactorrhea, then you may also and find increased level of the prolactins, and you need to rule out any prolactinomas or any hyperprolactinemia using cranial imaging. Now, you will see the next question you need to bring in your mind is uterus present or not. If the uterus is present, then you go for LH-FSH. If the levels are low, then there might be constitutional delay. If the levels are normal, they may be outward tract obstruction. If the levels are high, they may be premature ovarian failure. Now, you need to do karyotyping because in case of the high LH and FSH, mostly it is seen that it is related to the congenital problems like Turner syndrome. So Turner syndrome, you'll get premature ovarian failure types and picture of the LH-FSH, and it will come high. Now, uterus is not present, then in that case, you'll straight away go towards the karyotype, and you will start for differentiating between whether it is AIS. In AIS, it will be a male genotype, and in case of MRKH, it is 46XX. And sometimes free and total testosterone levels are high in case of AIS. That also helps in making diagnosis towards AIS. So I hope, so all of you are able to see the slide or not? Is the slide being shown on your, can all of you can see my slide?
Yes, ma'am.
Okay, so I think things are clear so far regarding how you have to take history, how you have to proceed with the examination, and how you have to use LH-FSH and different hormonal levels and scan to make out the diagnosis in your mind. So this, I wanted to go through this Ogram article so that you should, it's a beautiful article, you can all download it to understand this topic more easily. Let's just come over again to our presentation. Okay, so the recommendations for evaluation and who should be evaluated have recently been changed to those shown below. And you should know that indication for evaluation of an adolescent with primary amenorrhea is an adolescent who has not had menarche by the age of 15 to 16 years, and an adolescent who hasn't had menarche and more than 3 years have elapsed since thelarche. And an adolescent who has not had a menarche by the age of 13 to 14 years and has no secondary sexual development. So in that case, you need to rule out the different causes of primary amenorrhea. Now, the fourth one criteria is also has just been introduced, and that's an adolescent who hasn't had menarche by the age of 14 years, and there is a suspicion of an eating disorder or excessive exercise, or there is a sign of hirsutism or a suspicion of genital outflow tract obstruction. So if you find these three criteria in different cases, then it's labeled as primary amenorrhea. Important point is we'll always have to exclude pregnancy, and the most common cause in adolescent is usually anorexia nervosa, exercise, or chronic illness, followed by polycystic ovarian syndrome. So if they're coming with the primary amenorrhea, so first thing you don't have to bring in mind about genetic problems like CAIS, Turner, or things like that. So always go to rule out for these points in the history. And if you do not find any of such points, then in that case, you're going to think about all those cases which I've just mentioned like CAS and also the MRKH. But first of all, you have to find out whether there is any point given related to anorexia nervosa, exercise, chronic illness, and is there any hirsutism, weight gain, or polycystic ovaries given on scan or not. And if these things are present, then in that case, you go for ultrasound scan and then go for LH-FSH. Now, there may be two types of the amenorrhea I've just told you, estrogen deficient and estrogen replete amenorrhea. Estrogen deficient is associated usually with reduced bone mineral density and increased fracture risk, while estrogen replete amenorrhea can lead to dysfunctional bleeding. In that case, it will lead to endometrial carcinoma because of endometrial hyperplasia in the longer term. Now, how you have to clinically have to make a difference between these two, you will administer progesterone, that is Provera, 10 milligram orally per 7 days for 7 days, and you will see that these patients will have a bleeding after withdrawal, and this will show that this is because of estrogen replete amenorrhea. And if she doesn't get any menses after that, then that means she's coming in estrogen deficient amenorrhea. So we have just discussed about the history points. History points include the presence of galactorrhea, symptoms of thyroid disorder, weight loss, any organ or hirsutism or menopausal symptoms should be solved. Why menopausal symptoms? Because we have to rule out premature ovarian failure. And if the premature ovarian failure is present there, then you will ask questions like any weight, any hot flushes, bone pains, and if she has irritability, depression, if she has any dyspareunia or problems with the urinary problems, including urinary incontinence. So if these things are present, so this is more likely pointing towards amenorrhea because of premature ovarian failure. And then the premature ovarian failure have different causes. This will include Turner syndrome, Turner mosaic, and idiopathic causes, or it might be because of some chromosomal problems like Fragile X syndrome, and also because of chemotherapy or irradiation. I hope everybody is able to listen to my voice. Is everything clear so far?
Yes, ma'am.
Okay. In the examination, you have to see about the Tanner staging. So there are 5 different types of Tanner staging, and Tanner 5 breast development in the absence of the pubic hair or lack of breast development in the presence of adequate pubic hair. This should raise suspicion of a chromosomal abnormalities such as androgen insensitivity syndrome 46XY or Turner syndrome 46XO for stigmata of a chromosomal disorder for the signs of androgen excess. You will see hirsutism, acne, or alopecia. Now, I will show you at the end of the presentation what are the Tanner stagings, because these stages are not these developmental Tanner stagings from 1 to 5. This is not very necessary to learn, especially for solving these single best answer questions, but you should have a vague idea regarding what actually stage 1, stage 3, or 4 involves. Because if in SPA this comes, and they have shown you that the breast has developed this much amount of the areola or things like that, you should have an idea whether they're talking about Tanner stage 5 or 3 or 2, if it is not straightforward there. Most of the time, they're given in the questions, tennis stage 5, still she's having amenorrhea, and things like that, okay? So then in the examination, I told you about, you have to check about BMI to rule out the patient is not having amenorrhea because of low body mass index. You will also perform an external genitalia examination to see if there is imperforate hymen, if there is any of the transverse vaginal septum, or is there any vaginal agenesis. The investigations here, which I showed you in the flow chart, the basic investigations which we have to perform in all patients, and then the further investigations. And these are actually dictated by physical findings and history, what you'll do. So for all the patients, you'll go for LH, FSH, prolactin levels, TFTs, and pelvic ultrasound. In hyperprolactinemia, you'll arrange for cranial MRI. And in polycystic ovarian syndrome, you also do testosterone, sex hormone binding globulin, free androgen index, androstenedione, and 17-hydroxyprogesterone to differentiate between congenital adrenal hyperplasia and Cushing syndrome. Okay. A progestin challenge test is a means of evaluating the level of endogenous estrogen and the competence of outflow tract obstruction, and thus can be performed after the initial evaluation. Now, again, between the estrogen replete and estrogen deficient, you have to see whether this amenorrhea is because of estrogen deficiency. You will give progestational effect by giving progestational agent, that may be medroxyprogesterone acetate or Provera, for 5 to 7 days. And within 2 to 7 days after completing the course, the patient should bleed. If she does, then the presence of a functional outflow tract and a uterus lined by reactive endometrium sufficiently prepared by endogenous estrogen is confirmed. While the progesterone challenge test is very useful in determining hypoestrogenic states, there are rare conditions when withdrawal bleeding will not occur despite adequate levels of endogenous estrogen. So you have to remember this, and sometimes even after giving progesterone challenge test, there may be a possibility the patient may not bleed. So, but these occur in the rare conditions. So this happens where the endometrium is disutilized in response to high levels of androgens, for example, with polycystic ovarian syndrome or with high progesterone levels associated with the specific adrenal enzyme deficiency. So in that case, you will go with the investigations of testosterone, and also testosterone level will guide you whether there is a high progesterone levels or not. Whether there is increased level of the testosterone would guide you whether it may be because of polycystic ovarian syndrome or any adrenal enzyme deficiency, because in that case, testosterone level will be too high. But in case of the polycystic ovarian syndrome, the testosterone level will be high, but that will remain below the levels of 5, which is not that much high, but still higher than the normal population. So in that case, if the patient is not bleeding, then that means there is something going on with the levels of the endogenous estrogen. And this is because of desidualization, which takes place because of the higher levels of testosterone. The very high levels of testosterone should lead you to think about that it may be because of some adrenal enzyme deficiency leading to congenital adrenal hyperplasia, and because of the different levels of the enzymes deficiency, there will be increase in the levels of the progesterone. So this will ultimately make your diagnosis towards estrogen deplete amenorrhea still not bleeding when you are giving the patient progesterone challenge test. I hope I'm making this point clear for you all. If any of you is having problem in understanding this, please do let me know so that I can show you the diagram form where you can easily understand that why this sometimes these patients with the estrogen replete amenorrhea not bleed because of high testosterone level. I hope this is understood by most of all. All of you have understood this point or not? Should I move forward or not? I think all of you are clear now. Okay, so this is the table which we have already discussed. I showed you, so you can still go through this table. You'll take history, you'll do physical examination. The labs are here, which you'll perform for all of the patient, beta, HCG, TSH, prolactin, LH, and FSH. For making it easier for you, I've just written LH, FSH on the separate slides. So you'll see that the secondary sexual characteristics are present or not. Yes, it is present. Then you perform an ultrasound scan. If uterus is present, it may be a cause of obstruction. And if there is no obstruction, then you will do progesterone challenge test. And if she bleeds or doesn't bleed, you will divide them according to the estrogen deplete or estrogen deplete causes. Okay, so the next thing is that uterus is absent. You will go for karyotyping, and this will help you decide whether this is 46XY AIS or 46XX Mullerian agenesis. And if she is okay, then you will also you can also make your diagnosis by LHF set. If it's coming low, then these are the causes. And if it is high, then you will go for karyotyping, because karyotyping is necessary to exclude out Turner syndrome from premature ovarian failure causes. Okay, premature ovarian failure causes would be Turner, mosaic Turner, chemotherapy, or irradiation. So you can find in history that she had a hysterectomy or she had had a breast cancer followed by chemotherapy or radiation she received. And she might have Fragile X syndrome. So these are the important things which will help you make a different diagnosis. So memorize this diagram and the diagram I showed before, okay? If you miss any of the diagram and you want to take picture of it, please let me know so that I can go back to my slides and help you take those information so that you can save it for your exam. If a Jabin says she's not clear, why you're not clear, if a Jabin? Ifat, can you tell me what is your question? Hello, Ifat, are you there? Ifat, are you not able to understand about estrogen replete and deplete types of causes? Or what? Please so that we can clear your point and we can move forward. I think nobody is responding to me. So, okay. So I think she's talking about the patients. Okay, the challenge test. Okay, the progesterone challenge test. Yeah, I got it. Okay, so let me just take out a diagram for you to make it easier for you, all of you to understand. Output track CH pathway. Okay, so this is the diagram which I've just found from the Google. I think it will be visible for all of you now. Is it visible for all of you?
Yes, Dr. Asma, it is visible.
Okay, so this is a major pathway for adrenal steroid synthesis. So so it's an adrenal gland, and from the cholesterol, it's making different products of aldosterone, cortisol, and testosterone. This testosterone usually goes and sometimes converted into estrone, and this androstenedione is converted into testosterone. And this helps maintain our system of having a small amount of testosterone in our female bodies. This is a stress hormone cortisol, which has been actually made up in the adrenal gland. And the aldosterone, this is a salt sparing, this hormone that usually controls our salt absorption in our body and helps to maintain our body fluids. Okay, so what happens is that when the patient is not having menses, she's having amenorrhea for a longer period of time, and is suspecting that she may be estrogen deplete, or there may be a deficiency of estrogen. So in that case, when you give the progesterone, if she has good amount of estrogen in her body, then she should bleed when you give progesterone tablets to her. And these conditions would be polycystic ovarian syndrome, and this might be present the cases of other hormonal problems like thyroid problems. So in the cases like stress-related conditions, like anorexia nervosa or things like that. So in that cases, she will have estrogen very low quantity in her body, and maybe she's falling in the premature ovarian failure where she doesn't have any estrogen levels. So in that case, she will not have any estrogen in her body. So when you give progesterone test to that patient, she should not bleed. But there are some conditions in case of estrogen excess, like congenital adrenal hyperplasia and Cushing syndrome, where testosterone level goes too much high that it creates a pseudo picture of estrogen deficiency. And because of estrogen deficiency, the patient doesn't bleed, and it makes you confused whether she is coming in actual estrogen deplete causes or not. Am I making the point more clear now? So what happens, how this happens, that when we see that there are different enzymes which are actually causing these end products of progesterone and ultimately causing the formation of Sorry, actually, there was a problem with my internet that got disconnected. So here, so when there is any disturbance in the formation of these hormones because of defects in the enzyme, which actually cause the production of hydroxypregnenolone or deoxycortisol or androstenedione, because of this, there will be high levels of these progesterone in the body, and there will be drop in the estrogen level because there will be no testosterone or very high testosterone that will lead to decrease in the estrogen level. So once this happens, in that case also, when you give the progesterone to these patients, the patients are not going to bleed. Is that okay with you all? Okay, so in that case of estrogen excess causes, you will still find a pseudo low levels of estrogen picture. And when these patients are given withdrawal bleed by giving progesterone to them, the patients are not going to bleed. So in that case, you will perform a test called testosterone. And this testosterone will help you aid your diagnosis, because an LH and FSH. LH and FSH is coming normal and testosterone is coming high or normal, and the patient is not bleeding even after giving withdrawal bleed challenge, then you will go towards thinking of the causes like congenital adrenal hyperplasia or Cushing syndrome or polycystic ovarian syndrome. So these three causes are still pointing out towards, this or estrogen deplete causes, irrespective of whether she bleeds or does not bleed after the progestational effect which we give to the uterus. Is the point clear now? Yes, Ifar. Is the point clear now? Can we move forward? I think she's clear now, and I will now resume with the rest of my slides. So this is the second flow chart you need to understand. So you will do the history and examination of the patient. You'll perform tests like pregnancy test, TSH, prolactin levels. If there is some hyperandrogenism, then you will perform the test like LH, FSH, free testosterone. That means you see any hirsutism to the patient on the signs when you do the examination. Then in that case, you will go for these tests: LH, FSH, free testosterone, and then in fasting insulin levels and pelvic ultrasound. You will have these diagnoses in your mind because you have seen hyperandrogenism on the examination. So these tests will guide you towards CAH. These tests will guide you to help rule out polycystic ovarian syndrome. Then, if you find normal examination, there is no hyperandrogenism seen, then you will perform this progesterone challenge test. We'll give the tablets for 7 days, and then you see if she bleeds or not. If she bleeds, that means she is coming in estrogen deplete causes. That's because of immaturity of the HPO excess or polycystic ovarian syndrome. And exception to the rule, which I've just given you a bigger explanation of, like CAH and Cushing syndrome. Now, if she is estrogen deficient, then in that case, cycle with estrogen progestins, she will not bleed. And the causes are these ones. Okay, so these are the causes which are actually coming in estrogen deficient one. She may have a pregnancy, she may have a uterine adhesion, she may have a premature ovarian failure, she may have a failure to produce estrogen progesterone because of irradiation or chemotherapy. She may have hypothalamic causes, including stress-induced, chronic illness, exercise-induced medications she's taking, or eating disorders. So in order to rule out between these three columns, now you will perform LH and FSH. In LH and FSH comes low, then go for these causes in your mind. And if it is coming high, so that means premature ovarian failure. So is the point clear for you all? And why we perform LH and FSH? Because they may be a cause of pregnancy and uterine adhesion. So when you give challenge, withdrawal challenge bleed, she didn't bleed. Now you came up with these three columns in your mind. Now you started her on estrogen progesterone pills, and once you put her on these pills, she will now then start bleeding. So you will rule out pregnancy test, of course, by doing pregnancy test. If the UPT is present positive, so you're not going to start that patient on estrogen progesterone pill, of course. But if the UPT is negative, so in that case, you start her on these cyclical pills, and then she should bleed. And if she's still not bleeding, so that means she's coming up with the cause of uterine adhesions. And then you can go for the hysteroscopy to see that whether these adhesions are present or not. And in that case, you're going to give symptomatic treatment accordingly. And if she bleeds, you perform LHFSH. Now, the hormone may come up high or low. So you will treat the causes accordingly. I hope everything is clear so far. Now, these, again, hypothalamic amenorrhea, so reduction in the frequency and possibly amplitude of GnRH pulses, it results in the failure to stimulate sufficient synthesis and secretion of the FSH and LH by the pituitary gonadotroph cells. And it's going to lead to a degree of hypo state. Okay, patients have low LH, low FSH, estrogen levels with preserved sometimes LH. Okay, and FSH responsiveness to GnRH. So if these things are responsive to GnRH, so the treatment automatically will lead to GnRH pulses or analogs. Okay, so you give them this, you will create, you will give them LH-FSH from outside source. The patient will start bleeding by producing LH and FSH, estrogen and progesterone. The most common cause are excessive weight loss, exercise, chronic illness, stress and medication. A number of rare hypothalamic space occupying lesions can present with the amenorrhea. Other tumors, like causing pituitary stalk compression, may prevent delivery of these GnRH to the pituitary, again causing amenorrhea. So how the tumors prevent the release of this GnRH analog and how they cause amenorrhea. So it's actually compression that's actually causing these symptoms to occur, and these patients are presenting with this problem. So you go for CT scan or things like that for bigger, diagnosis. You go for bigger investigations like MRI and CT scan. You consult your colleagues like your physicians and your surgeons, and they're gonna do surgery for those patients, and then they're going to be relieved by this problem. Now, the other problem is Kalman syndrome. It's actually a very rare congenital absence of the development of neurons, GnRH neurons, which exist between the hypothalamus and the pituitary. And this comes in about 1 in 50,000 of the cases. The condition may be sporadic, and it is sometimes autosomal dominant or X-linked recessive disorder, and may be seen in association with anosmia. So you took a history, and there is a smell history. She's unable to smell since childhood, or she developed, so there may be a genetic conditions which may be associated with the development of amenorrhea. She also can bleed if you give her GnRH analogs. Failures of the GnRH message reaching the pituitary prevents initiation of SSH and LS synthesis with primary amenorrhea, and thus, because of this, there is a failure of sexual development. Now, pituitary condition, how they affect and cause amenorrhea. Hyperprolactinemia, usually a result of prolactin secreting tumors, macro or micro, and accounts for approximately 15% of secondary amenorrhea, may present as primary amenorrhea. So circulating concentration may be moderately increased of this prolactin level in certain other conditions beside this pituitary prolactin secreting tumors. So we have in hyperprolactinemia 3 types of conditions. One patient is presenting with macro tumors, and one patient might be presenting with micro tumors, and they may have a history of menses followed by secondary amenorrhea. But if the patient is presenting in a younger age, she might present with primary amenorrhea. So check the prolactin levels. If she gives a history of headache and any discharge from the nipples, and then you do the and the visual disturbances, you do the prolactin levels, and this come up very high, above 5,000 range. So this will make our diagnosis go towards macro. And if the levels are low, below 5,000 and something in between 3,000 to 5,000, so that is differentiating it from the microadenoma. Still, you have to get it confirmed from CT scan or MRI in collaboration with your colleagues in neuro department. Now, the other conditions where you might find prolactin level, but you do not have any history of headache or nipple discharge or visual disturbances, then you may check that she doesn't have any polycystic ovarian syndrome. She doesn't have any autoimmune condition like SLE, rheumatoid arthritis, chronic renal failure, hypothyroidism, and even stress can also lead towards increased level of prolactin levels. But these prolactin levels are not that much high when we compare it with the micro and macroadenoma. So these levels would be, less than 1,000, but this would be raised above 700 or something like that. So cannulated venous samples can be collected during bed rest if stress related. So it will help us rule out whether it is this prolactinoma is because of stress or not. Pathological hyperprolactinemia will be associated with amenorrhea, and in most but not all the cases, galactorrhea. Bitemporal heminopia should always be sought at first presentation, since it may indicate the need for urgent imaging of pituitary to exclude an expanding macroadenoma. Some macroadenomas and most micro will respond to drug therapy, and these are bromocriptine and cabergoline. And bromocriptine is usually associated with the GI side effects. So the choice of drug most of the time is cabergoline, which has just been introduced because of reduced GI side effect. It has gained popularity and allowed a less frequent and more convenient dose regime. Resistant cases and some macroadenomas will also require surgery like hypophyseectomy. Okay, so there is one more tumor, craniopharyngioma. So these are epithelial tumors. This also arises from the craniopharyngeal duct in the cellar or paracellar region and is associated with LH and FSH deficiency. So it will lead to the amenorrhea, which is estrogen deficient type. Then comes the polycystic ovarian syndrome in the ovarian disorders, and all of us know that how it presents. Gonadal dysgenesis. Gonadal dysgenesis refers to the number of conditions in which gonadal development is abnormal, which leads to the streak gonads. Then estrogen levels are low and levels of LH and FSH are markedly elevated. So they will give a picture of premature ovarian failure because of streak gonads, which are not responding to the level of LH and FSH, ultimately leads to decreased level of estrogen and progesterone, and the patients are not going to have menses. The most common cause is Turner syndrome, 45X karyotype. The other forms also exist, which are called as pure gonadal dysgenesis, where you might find karyotype like 46XX. But this, despite of having the normal karyotype, still the patient is having amenorrhea, then your karyotyping might confuse you. So you just, on the basis of LHFSH, you'll have to make a cause of, premature ovarian failure, and you'll have to explain that it may be because of gonadal dysgenesis. Then there is a very important syndrome called Swear syndrome. It's an XY gonadal dysgenesis, and there is a uterus, but it doesn't have, ovaries along with it. So the only uterus is present, and because of and if the ovaries are present, these are very streaked ovaries, and sometimes may present with ovarian tumors like gonadoblastomas. So because of unresponsive ovaries, so you might find a picture of premature ovarian failure in the Swear syndrome, and this may also lead to the problem of amenorrhea. So primary ovarian failure, the ovary contains a finite number of primordial follicles in the lifetime store of the potential ovulation. The number of primordial follicles in this pool varies from individual to individual and can be depleted by medical interventions like chemo and radiotherapy. So there is frequently a family history in such patients, or there may be manifestation of autoimmune diseases leading to this autoimmune uveitis. So because of these two things, you just have to take a history, and the history points are going to make clear of you the diagnosis of amenorrhea and further assisted by LH and FSH levels. Rare causes include galactosemia, even in the treated patients. That's a very important thing. You have to see it in solving single best answers. Mumps, uveitis, trisomy 21, female fragile X carriers, sarcoidosis, Turner syndrome, mosaicism, all may lead to secondary amenorrhea and also primary amenorrhea. So Turner syndrome, which is non-mosaic, usually presents with the primary amenorrhea. And this is also a very important thing. Cessation of periods will be preceded by several years of irregular or more frequent menses with hot flushes, sweats, and other hypoestrogenic symptoms like dyspareunia or urogenital problems. Now, Mullerian anomalies. The Mullerian anomalies involves, it's actually a failure of canalization of the Mullerian duct at any level. So this will cause primary amenorrhea. Imperforate hymen comes in the very frequent type of the Mullerian anomalies, which might result in the amenorrhea presentation with normal sexual development. She may also have intermittent abdominal pain, difficulty with micturition, and a palpable lower abdominal swelling. Examination will reveal a bulging. You will see a bluish membrane at the lower end of the vagina, and the treatment involves surgical incision of the membrane. If there is obstruction of the vagina or cervix at a higher level associated with normal functioning uterus, This will be compounded by the painful distension of hematocolpos, hematometra, or heme peritoneum. So in all cases, surgery will have to be performed to establish the continuity of the genital tract. MRI gives an accurate diagnosis. So these patients have an absence or hypoplasia of the vagina in case of Mullerian agenesis, and the uterus may be absent or abnormal, but sometimes it may be presented by rudimentary biconoid cords present. Ovarian function, growth, and development are normal, and the peripheral karyotype we perform will be 46XX and female. So this is actually, we call this condition as MRKH. So there is a high association with other anomalies when we are suspecting this MRKH, and this occurs in 1 in 4,000 to 5,000 female births. And there is sometimes renal tract abnormalities like ectopic kidney, renal agenesis, horseshoe-shaped kidneys, and abdominal collecting ducts, 30% of the cases, and 12% of the cases you'll find skeletal abnormalities. So you'll have to do additional investigations of MRI along with that. Okay. Okay, the androgen insensitivity. So this is a testicular feminization. It's an X-linked recessive inheritance. A blind ending vaginal canal is found with an absent uterus. The gonadal sex is male and the patient has testes with XY karyotype, but the patient is phenotypically female, but with the absence of sparse pubic axillary hair. Growth and developments are normal. So she is a taller than average. Breasts are large, glandular tissue is sparse, nipples are small, and areola are pale. Labia minoras are usually underdeveloped. So the patient comes with you in the clinic with amenorrhea, and she is looking like female. And when you do examine her, she has the breast development in a stage 5, and she is taller than normal. Her BMI might be small in, it would be around 16 to 18, and she have a sparse pubic and axillary hair. Now you should perform an ultrasound scan to see the uterus present or not. If the uterus is not present and there is a blind ending vagina, go for the diagnosis of AIS by confirming it with the karyotype. And if it is GIST XY, this is androgen insensitivity syndrome. These patients can have, history of inguinal hernia and history of surgery in the childhood because of some swelling in the lower abdomen. When you, explore it, then you're going to know that that was actually gonadectomy done because it was, or the testicular organs that was presented as a hernia in the lower abdomen. And it has to be removed because it may lead to the formation of the gonadoblastoma and also the tumors. So the underlying condition is actually because of androgen receptor defect. The circulating androgens are normal or slightly elevated, but the critical steps in the sexual differentiation which require androgens fails to take place and development is totally female. So the total androgen hormones was released, but and anti-Mullerian hormone was also released in that body. AMH level caused the suppression of the Mullerian ducts to develop into the uterus, and because of this, she didn't have any uterus, any vagina, only a small part of the vagina, lower 1/3, was developed, and the testosterone level was increased in the body, but because of receptor defect, it couldn't act on it, and this causes the development of the breast, but sparse pubic hair, and led to the phenotypically female with genotype of male karyotype. So the testes may be intra-abdominal, but are usually seen in the inguinal hernia. So there is no spermatogenesis in these testes. Because of increased risk of malignancy, the gonads should be surgically removed. And however, this is the best left until after puberty because tumors do not occur prior to this period. And this is done to achieve the development with endogenous hormone. And after that, once the puberty is reached, you should take out those testes. Now, this is in contrast to the other cases where gonads with Y chromosomes should be removed as soon as diagnosis is made. Following removal, you will start giving the patient estrogen replacement therapy because sometime before that estrogen was being released, and now because of gonadectomy, she might have features of premature ovarian failures. In order to avoid that, you may give these patients estrogen replacement therapy. Now, let's come towards the imperforate hymen. It comes in 1 in 1,000 and it may be diagnosed in the childhood and may also be missed and may present in adolescence with cyclical abdominal pain and primary amenorrhea. And the physical examination, you're going to find bulging bluish hymen behind which is a blood-filled mass in the distended vagina in the form of hematocele pores. Transverse vaginal septums, 1 in 80,000 is the presentation because of incomplete fusion of the Mullerian duct portion of the vagina and the urogenital sinus component. The thickness and the placement of the septum may vary, lower vagina, middle vagina, or upper vagina. 80 to 90% occur in the middle of the vagina or the upper vagina, and the external genital examination appears normal. The one rare condition which might be associated with these transverse vaginal septum is that sometimes there is perforation in the septum, and patient may still present with amenorrhea and hematocele pores because these perforations are very small. But if the perforation is present, they may come with oligomenorrhea. So you need to do on the examination to see what level of the transverse vaginal septum is present and is there any perforation present or not. Then other malformation of urogenital tract or rectum may also be associated with it. So when you see that there is a problem with the transverse vaginal septum, you need to do some initial investigation to rule out these urological tract problems and ductal problems as well. Now, thyroid disorders, these are hypothyroidism, may present with oligomenorrhea, and you will have to confirm it if she gives history of weight gain, lethargy, depression, and in that case, you will do the TSH level, and if it becomes raised, it will point out towards this diagnosis. Hypothyroidism, all of us knows, 20 to 60% of menstrual irregularities, and amenorrhea in 20%. Congenital adrenal hyperplasia. So this is due to the deficiency of 21 hydroxylase enzyme and 11 beta hydroxylase and 3 beta hydroxysteroidase dehydrogenase. So these are the different levels of the enzyme which will increase in the levels of the progesterone like pregnenolone, hydroxypregnenolone. So the progesterone level would increase, this lead to pseudo amenorrhea, decidulization, and this pseudo decidulization will cause amenorrhea in these patients. This may present in the classic form and non-classic form. Yes, is there any question?
Yeah, can I see the slide with vaginal septum? I just missed that.
Okay, no problem. So you're talking about this transverse vaginal septum slide?
Yes, I just wanted to, yeah, that's one. Yeah, thank you so much.
Okay. Okay. Can we move forward now?
Yes, please.
So this pathway I showed you before I was explaining about decidulization, how it takes place and how even after giving progesterone, the patient doesn't bleed. Okay. So 3 different levels of enzymes causes increased level of the progesterone in your body, leads to the decidulization and amenorrhea. 2 classic forms, 2 forms through which it may present. Enzyme deficiency is complete or partial. So the classic form is when there is a complete deficiency of an enzyme, it comes in infancy, with soft wasting or ambiguous genitalia, and 1 in 16,000. So it's rare. And in non-classic form, one of the most frequently seen autosomal genetic disorder occurs in approximately 0.2% of the population and may present in the childhood characterized by premature puberty and in adolescence by hirsutism or the problem of amenorrhea. Now, Cushing syndrome is also something we usually do not see when the patient is coming with the problem of amenorrhea in our clinic. So it's actually high circulating levels of the cortisols. In adolescents, it's syndrome is most commonly frequently associated with iatrogenic exogenous administration of steroids, and other causes may include hypersecretion of the corticotropin by microadenoma of the anterior pituitary. This is called as Cushing disease. And secretion of these corticotropin by an adrenal tumors, or occasionally ectopic production of corticotropin by non-pituitary tumors such as carcinoma of the lungs. So this is something which you'll see in the Cushing syndrome. So here, what you saw, that there may be in the history, you will see that there is a history of taking excess steroids, or there may be a problem. You will find it on the CT scan that there is some microadenoma in the anterior pituitary that leads to the secretion of corticotropin, ultimately increasing the levels of the cortisol. And the third scenario is when there is some ectopic production of this corticotropin by some adrenal tumor or by some, small cell carcinoma of the lung. This leads to an increased level of the corticotropin and can ultimately raise level of the cortisol in the body. So the cortisol production would be increased. So there will be switch off of the cycle towards production of the testosterone and the steroids, and this leads to the decreased amount of the estrogen and progesterone in the body, which will lead to the pseudo decidualization and will cause amenorrhea in these patients. And these patients are not going to bleed even after you give progesterone to these patients. These are the different diagrams you should know of the Mullerian agenesis. Nobody asked in the question paper, and this is not that much important, but in the Viva point of view, you should know that there may be unicornoid uterus with communicating, non-communicating horn. So this is type 2 levels of the Mullerian agenesis, with having cavity, with having no cavity, no horn, hypoplasia or agenesis, vaginal, where there may be vaginal hypoplasia, cervical hypoplasia, fundal hypoplasia, tubal, or combined hypoplasia, or the type 3, which include didelphys uterus, type 4, bicornuate uterus, which may be associated with complete or partial resection, and septate uterus, complete or partial resection. And the difference you note that in the type 4 and type 5, what's the difference? There are two cavities here, and in the septate, okay, so in the septate uterus, you will see the horn from outside. It's you won't be able to find it when you do laparoscope. So you won't feel any problem in the uterus, whether it has a septum or not. But once you will pass hysteroscope, then you will see that the septa is coming down below. So to help you decide whether it's a septate uterus or a bicornuate uterus. So this is how you, when you are suspecting all these kinds of Mullerian agenesis, you will make the diagnosis by laparoscope and hysteroscope combined. And the sixth type is the arcuate uterus. You do not find the septum to be elongated and dividing the cavity into two. When this is not a condition, you see on the laparoscope, the uterus from outside is circular and there is no septum from inside, but an indentation, which is about 1/3. So you will label it as type 6, type of Mullerian agenesis, arcuate uterus. Why we are reading all these things types? This is not important in amenorrhea, but the only important thing in our type of amenorrhea to deal with it is type 1. Sorry, I cannot hear you. Who is this speaking?
प्योर ड्रिंकिंग वाटर है सिर्फ पैकेट कोकोनट वाटर होते हैं ना, वो प्रिजर्वेटिव होता है, इसमें बिल्कुल प्रिजर्वेटिव नहीं होता.
I think somebody's mic is on. Who is with the name of iPhone? Can you please switch off your mobile? It's making our presentation a little bit, problem. So here you see in our topic of amenorrhea, you should only know the type hypoplasia or agents type 1. Because of this problem, the patient may present with problem of amenorrhea. Otherwise, these rest of the types are only important when we are discussing another topic of frequent miscarriage or infertility. Okay. Okay, so this is the transverse vaginal septum diagram. Here you see A, B, C, lower third, middle third, and upper third of the vagina, transverse vaginal septum. So this may how the patient may present. It may have different, perforations inside of it, and this is how you're going to see that whether this is perforated or not. And then sometimes this will on examination will look like pink in color, while imperforate hymen will look like blue in color. Now here, longitudinal vaginal septum. So this may also be present in most of the patients. The patient may have a problem of amenorrhea, or she may present with oligomenorrhea, or she may present without having any problem of menses. She's having regular menses, but she might present with the problem in infertility and dyspareunia. So when this two complaints are present, you just divide these, the septums to ease off her problems. So this is an ultrasound feature which shows hematocele pose. So this is how you find this is bladder, and this is how you're going to see the uterus having blood inside of it, and this is actually the lots of blood with the septum below it. You see how hematocele pose is actually coming on MRI. So this is actually, the referral pathway. You should all know that when the patient comes with the obstructed outflow tract obstruction, with the absent vagina, and with the transvaginal septum, with the absent cervix, refer them on to the tertiary care centers. And imperforate hymen, you can do it even in the secondary center. You can just give an incision and get the patient relief of the problem. Rudimentary uterine horn, secondary or tertiary center, depending on local expertise, because in that case, you'll just do the laparotomy or might do removal of the horns, through laparoscope, and this depends upon the expertise availability in tertiary care, secondary care. Now let's just discuss about MRKH. So this was the table I showed you in the diagram form, American Fertility Society classification of congenital uterine abnormalities, class 1. So class 1, we are dealing here with MRKH syndrome. So MRKH syndrome is classified into 3 types. It's very detailed. I've just mentioned these types. These are not very important in terms of, for your SPA question for the MRCPI exam, but you should know that there is a typical type 1 associated with isolated symmetrical UV aplasia or hypoplasia, or atypical type 2, asymmetrical UV aplasia or hypoplasia, absence or hypoplasia of one or both fallopian tubes, and malformations in the ovaries and or the renal system. MURCS, Mullerian duct aplasia, is a type 3-1 renal dysplasia or cervical somite anomalies syndrome. UV aplasia or hypoplasia with malformation in the skeletal system and or the heart, muscular weakness, and renal malformations. So this is how you will see the presentation of MRK syndrome. The only Mullerian duct that got developed was this, small tubes and the ovaries, you could see. And there is no uterus. There is a connective tissue, and there is only 1/3 of the vagina dimple, which you could see outside. And this is developed only because it is formed by the ectoderm. Anatomical abnormality. In type 1 MRK syndrome, the caudal portion of the Mullerian ducts are involved. This is characterized by the presence of 2 rudimentary uterine buds connected by the peritoneal fold, normal fallopian tubes, absence of the upper part of the vagina. In type 2, there is asymmetrical hypoplasia of the uterine buds with or without hypoplasia of one or both fallopian tubes. 10% of these women have a rudimentary uterus with small endometrium, and as many as 25% have cavitated Mullerian remnants. The ovaries are absent, hypoplastic, or extrapelvic in 10 to 15% of the cases. So it's a small amount of the information, not that important as compared for in terms of the exam point of view, but I want you people to know a little bit of it because sometimes the presentation may be of this type. The other associated problems which might be present with these MRKH is renal abnormalities. 40%. The kidney may present, one of the kidney may not be present. There may be ectopic kidney. There may be horseshoe-shaped kidney. There may be ectopic ureter. 12 to 20% of skeletal problems. and sometimes it may have Klippel-Feil anomaly, fused vertebrae, where there is fused vertebrae, radial aplasia, absent thumb, scoliosis, and radial hypoplasia. The patient may not be able to hear because of conductive deafness, and there may be cardiac malformation. Etiology, we do not know. Maybe teratogenic exposure or sporadic origin with polygenic multifactorial inheritance. Clinical presentation is 80% primary amenorrhea, and when you do the examination, normal secondary sexual characteristics, but with a short blind ending vagina. General examination may show musculoskeletal abnormalities. If functioning endometrium is present, then cyclical abdominal pain may be the presenting symptom, necessitating the removal of the horn. So this is the reason why I wanted you to know about the types of the MRKH, because the presentation may be this one. Other rare presenting complaints are subfertility and dyspareunia. Now, DD, you might get it confused with the congenital and androgen insensitivity syndrome, and you will differentiate it by doing karyotype, which will reveal 46XY. Okay, so the other DDs which you'll see is that of imperforate hymen and agenesis of low part of the vagina and transverse lower vaginal septum. But when you do the ultrasound scan, then you will be able to find uterus and all of it, outflow tract obstruction causes. So now, is the slide, all of you is able to see the slide or not? Is the slide visible to all of you? Okay, let me just reshare my slide. Okay, so this is actually, so these are the DDs which you'll see. So congenital androgen, complete androgen insensitivity syndrome, differentiated with the karyotype 46XY, imperforate hymen, agenesis or low part of the vagina, and transverse vaginal septum, which may be of lower vaginal type. But these diagnoses, you will, separate it when you do the ultrasound scan. Once you do the ultrasound scan, you'll find the uterus. And once the uterus is not here, the only DDs would be CAIS and MRKH. So you will differentiate it by doing the karyotype. Okay, so the further investigations. Investigations for the MRKH is 2-dimensional ultrasound scan, 3-dimensional is more accurate one, MRI. And MRI is very useful because you're also going to find out other problems like renal, skeletal, and heart problems, and also the deafness. In case of, deafness is not going to be seen in the MRI, but these 3 problems would be easily seen when you are making a diagnosis of MRKH. Now, you'll do the endocrine profile, LHFSH is okay in these patients, testosterone will be normal in these patients, and karyotype would be 46XX. What is the management? See, the only management for these patients, as they do not have a uterus, we cannot make them bleed. So the psychological support is very, very important for these patients, because they cannot accept that with such a karyotype, they are having absence of the uterus, and they are never going to have menses, and they are never going to have a baby. So the counseling part is one of the strongest thing, which usually involves in their management. And the diagnosis must be disclosed sensitively, and the way the diagnosis is explained may have a lasting negative impact on the woman's psychological status and self-esteem. Extensive counseling and psychological support is very, very important at the time of diagnosis and later in life. So it may involve cognitive behavioral therapies, it may involve group-based interventions. Now, coming towards the creation of the neovagina is the other type of help you can give to these patients. So a functional vagina should be enable these women to have a comfortable sexual intercourse, and you can do it with the dilator or vagina up to a length of about 7 centimeters, gradually increasing it. Okay. So the timing of treatment should be individualized, and treatment may be postponed until the woman is actually considering becoming sexually active and is emotionally able to cope up with the treatment. And in this, psychological preparation plays a vital role in the management of such patients. Now, coming towards the non-surgical treatments. So what vaginal dilators comes up high, and you do it with the Pyrex R tubes of gradually increasing sizes, and the success rate of 81 to 88% is seen. Now, the surgical treatment options, they've got lots of surgical treatment options, but we have McIndoe procedure, we've got Dado procedure, we got Figetti procedure, and we got sigmoid vaginovulvoplasty, Williams vaginovulvoplasty, but you need to remember only the McIndoe procedure, the Figetti's procedure, and the Dado procedure. So the McIndoe procedure involves, the Figetti procedure, sorry. So the Figetti procedure is to create a new vagina, but gradually stretching of the vaginal skin. And the procedure involves placing an olive-shaped bead onto the vaginal dimple, which is pulled up gradually by threads that run through the olive from the perineum into the pelvis subperitoneally, across the vesicorectal space and out through the abdomen, where they're attached to the traction device. And now you give this traction, gradually increase this traction to 1 to 1.5 centimeter per day. And you do it until you achieve, 7 centimeter of the vagina. And it takes about 7 to 9 days to create the new vagina. Now, Dado procedure. So Dado procedure is creating a new vagina using women's own peritoneum lining. And the procedure actually involves dissection of the rectovesical space and abdominal mobilization of these peritoneum to vaginal fornices, and then creating the new vagina. So post-operatively, in order to maintain the vagina doesn't collapse, you need to place a mold, which is inserted for 6 weeks, and you need to use regular vaginal dilators until she starts commencing her own sexual activity. So now, if she says that, what are my fertility options? Now you have resolved my problems like that, but I want to have a baby of my own. In that case, the only thing is IVF and surrogacy. So this is a beautiful diagram. I found it from one of the talk articles, and this will help you understand that XX and XY, and XS leads to the ovaries, and how it gets development, XS gets into development of the ovaries. And sometimes the ovaries, when they are not working, so so the bitemporal gonads, so these testes, how these genes usually affects the development of these gonads and causes the development of internal genitalia and external genitalia. So the SRY genes, along with the testes, that they release testosterone, and they maintain the Wolffian ducts, leads to the development of the male. And these testosterone also convert into DHT, the active form of the testosterone, and also causes these male development when they act on the receptors. Now, AMH level is also released in these patients, and this causes the obliteration of the Mullerian ducts. This or leads to the this is how XY leads to the development of the male pattern of the growth. Now, in the XX ovaries, there is no testosterone production. This leads to the obliteration of Wolffian ducts. So because of this, no dihydrotestosterone, which is an active form of testosterone, is seen. So because of this, the female develops. There is no AMH, and because of this no AMH, the Mullerian ducts develop. This leads to the formation of uterus, tubes, and ovaries, and a female develops. So this is a whole diagram you should know, and that this is how the normal development things occur. But if in case there is a gene defect, there is a problem in the SRY gene, or there is a problem in the receptor, which we usually see in the congenital adrenal hyperplasia, then in that case, testosterone is being produced, still it's not acting on these receptors, will lead to the formation of external phenotype of females. And because of AMH is being produced, so it will lead to the production of the obliteration of the Mullerian ducts. So there will be no uterus. She will have XY genotype. She will have testes. But because of this defect, the patient is developing into female. These are the examples of classification of the differences of the sex development. Take a picture of it and go through this, because it will help you understand 46XY disorder, 46XX disorder, which I've just explained you, and also the sex chromosomal disorder. And these are some important lines. I would like you all to make a picture of it as well and memorize it, because it will give you good understanding of differentiating how CAIS is being differentiated from the MRKH. So there is a resistance of the androgen receptor, which I've just explained you in the diagram, or its mediators to the binding of the testosterone, and DHT results in the androgen insensitivity syndrome. In complete type, the karyotypes is XY, gonads and testes. Mullerian structures are not developed because of AMH level, and in the presence of minimal testosterone action, the Wolffian ducts are maintained in half of all the cases. At birth, the external genitalia is female. Breast usually develops because of peripheral conversion of estrogen from the testosterone. At puberty, phenotypically female will present with primary amenorrhea, but have a normal breast and a scant pubic and axillary hair. In childhood, they may have a bilateral inguinal hernias, which may contain undescended testes and needs to be taken out when they reach the puberty. Individuals with complete androgen insensitivity syndromes, they have usually been assigned a female gender in infancy and generally continue as such. But in partial one, karyotypes is XY, the gonads are testes, and the Mullerian structures regress under the influence of the AMH. However, differing degrees of insensitivity result in varying development of Wolffian structures. The external genitalia is variable, but hypospadiasis is common, and most patients are raised as male. So this is how you're going to make up your points of CIS, partial, complete, who's going to be female, who's going to be raised as male, and how the MRKH problems to solve, what are the different options we're going to treat the patients of MRKH with, and how by using the different flowcharts, you're going to solve the single best answers when it comes in terms of solving the questions like primary and secondary amenorrhea. Hope I've cleared all of your queries. So let's just go with the quiz. Who's going to answer this question after having so much discussion on primary and secondary amenorrhea? So there's a 40-year-old woman with BMI of 32 who is referred to gynae clinic with secondary amenorrhea. She has 2 children and her partner had a vasectomy 5 years ago. An ultrasound scan is performed showing normal uterus with a limited thickness of 6 mm. She has a typical PCOS appearance. What would be the recommended management of this patient? Any one of you? So I'm waiting for the answers, girls.
Please, can I ask you one question? Because I have confused with androgen insensitivity syndromes and between 5-alpha reductase.
So 5-alpha reductase why 5-alpha reductase is actually the enzyme which causes the conversion of testosterone into the 5-DHT testosterone, the active form of the testosterone.
Yeah.
And because of this, the testosterone would not be available. Okay.
Outside, you mean
So
outside.
in
I
that,
mean, phenotypic,
yeah,
it will
outside.
be a confusing phenotypic, but inside, is it male?
Yes. So inside it will be the male type because the testosterone is there and the testicles are there, and they might be the partial development of the there will be no uterus because AMH is still present there, and the testosterone level will be causing the development of the male from inside genotypically. But externally, the parents would be congenital androgen insensitivity syndrome. So in that case, you will go with the karyotype. And the second thing is that you will, in such cases, go with the testosterone levels of DHT levels and the free testosterone levels. So if the 5-DHT levels will be decreased, so in that case, it will be confirmed that there is a problem going on with the receptor and the levels are reduced. But in the cases of complete androgen insensitivity syndrome, there is receptors are normal, the 5-DHT would also be reduced. So the picture would also be coming up the same, but then you do a further test of the receptors, and this will help you understand that what actually causing it to be, why these DHTs are coming reduced. But once there is a problem with the receptor of 5-alpha reductase problem, only then you will be able to differentiate it from the congenital complete and androgen insensitivity syndrome. Otherwise, they will completely be looking like complete androgen insensitivity syndrome like patients. So you cannot, this will be a confusion between, unless or until you find an information regarding the receptor.
Doctor, I mean, I'm
Is
confusing about appearance. I mean, if for androgen insensitivity syndromes, a female, nice-looking female with blind vagina, but for 5-alpha reductase, if there is any secondary sex character of female like breast, or there is penis, if there is any small vagina, that I'm confused.
No, so yes, yeah. So they will have a similar picture like congenital CAIS because of the DHT type of the factors. So here, let's just go back to the diagram I just showed you. This will help you explain that how it is different from the CIS. So here, this prior diagram. So there is only a problem with the receptor. So there will be testosterone, there will be AMH, there will be obliteration of Müllerian ducts, but the testosterone would lead to the maintenance of the Wolffian ducts. So there will be male structures. There will be testes, and there will be the presence of Wolffian ducts, which is usually not present in case of, these internal genitalias will be present.
Who congenital adrenal hyperplasia.
Yeah, but external parents would be like female.
Yeah. I mean, what about if there is short vaginal like that one, or there is no, because there is internal organ here. They have internal organ in androgen.
Yeah, so they will come in the hermaphrodites, Yeah, they will be hermaphrodites, and they might have, presence of the maintenance of Wolffian ducts. They will be having testes, and they will be having the blind ending vagina as well. So this actually, will help them differentiate from the congenital AIS type of the people.
Okay. Yeah.
Okay. Am I making my point clear?
Yeah. Okay.
So they may also be presenting, might be presenting in your OPD with the amenorrhea problem. So once you do it and you find the Wolffian ducts, so that means there is something, related with the hermaphrodite, and that's because of the 5, alpha reductase deficiency enzyme.
You mean incomplete, there is absent, like the, I mean, receptor.
Yeah,
In partial, it may be when they get puberty, it will get some androgenic effect partially, outside, I mean.
yeah, as well, yeah.
Okay. Now it's better. So there is two entity. We have androgen insensitive syndrome and we have 5-alpha reductase deficiency, whether partial or complete. Doctor,
Yes,
it's androgen insensitive syndrome, so it's X-linked, while 5-alpha reductase, there is no inherited?
Yeah, I'm not confirm about that one, but it is also sometimes, it's sporadic, it may be autosomal or X-linked. Any of it, the presentation may be of any, it may be X-linked, it may be, autosomal one.
So, doctor, that one, androgen insensitive syndrome, that one with running in the family, they say it's maybe sister or somebody in the family, they have androgen insensitive syndromes, right?
Yeah.
Okay.
Yes, you'll have to ask about it in the history as well.
Okay, now it's complex, I know, but now it's better than before. Thanks.
Is there any other questions related to this topic? Okay, so this is the question which I've just given to you. So give me the answer of this. That's very easy one. It's just to, shake you that you've listened to me tightly. So who's going to answer that? Okay, so many of you have answered B. So that's a good thing. You're approaching this scenario very well. So once you think that the patient is having polycystic and you are going to check it with the gestational effects, so you'll do it by giving withdrawal bleed. So that's a good one. So the next one is, what is the karyotype of a woman with MRCPI syndrome? Can I have the answers, please? The easiest one. All of you can see my slide? Is there any problem with the slideshow? As I can see that nobody is answering my question. Okay, so the next question is, what's the karyotype of a woman with MRCPI? So that's the simplest answer I would expect you all to give me.
It's 46XX.
Yeah, that's great. So this was all about, today's topic. So I think if you have any of the queries related to this topic, please let me know. I'm here to address them. And then we can move forward for explaining about how our course is going to be conducted. So this is the last question. So 20-year-old girl, she attends the gynae clinic with her mother. She presents with a primary amenorrhea. She has a BMI of 19. She has a normal breast development, but a short ending, blind ending vagina. There is a scanty axillary of pubic hair, no axillary pubic hair. So what is going to be the diagnosis? What's the diagnosis, girls? Hello, everyone. I'm just waiting for your answers. Can you see the slide now? Yes, that's great. So that's complete androgen insensitivity syndrome. Now here, if I change the scenario, she has a breast. She has a, BMR of 19. She presents with the problem of, infertility. Now, we do her karyotype. We do an ultrasound scan. She has a uterus, but on karyotype, she has 46XY. So what will be the diagnosis? Options are similar. That's great. Who has answered D? Ayman Salim. Ayman is right. So that will be Sware syndrome. So this is how you will solve your questions in your exam. I hope I made most of my point clear. The questions like, 5-alpha reductase deficiency, that's a good thing that you've asked and got yourself clarified for this topic. These are very difficult questions, and I don't think the questions are going to be that much of difficult level, but you should be able to, follow the flow charts, how you have to do your investigations, at what time and order, and what are the diagnoses that will lead you to the ultimate, exclusion of the different DDs of primary amenorrhea. So any of you have any queries or questions related to this topic? I'm here for 5 more minutes, and then we can close our session. Although you just joined it, we just finished our
Asma, for gonadal dysgenesis, you mean the ovary either small or the testis is small for gonadal dysgenesis, like in case of Sauer syndromes, it's something like that, you mean?
Yeah. So in Sware syndrome, the patient, she may present with sometimes with the amenorrhea, and usually present with the amenorrhea. Why? Because these patients will be there in the OPD and with the streak ovaries. They will have a streak ovaries, or they might have a testes, and they will have a genotype of 46XY, but they will have a uterus of their own. And it's not still understood that why the uterus is there. It may be because of partial inhibition of the AMH level. They get a pseudo uterus, and when they usually come with the amenorrhea problems, so we usually give them cyclical or prime the uterus with estrogen and progesterone and make a little bit higher of it. And sometimes there is no AMH levels, and because of this, they usually get development of these Mullerian tract, and there is a uterus, but a very small vagina. So most of the time, they usually present with us with a problem of secondary amenorrhea, or sometimes with the primary amenorrhea, and sometimes with the infertility. And when we do the karyotype, these have a 46XY, and the incidence is similar like that of the congenital androgen insensitivity syndrome. And because of this, we can give them an option of having a baby by using donor eggs, and even sometimes if we could by some instance or by chance find out some eggs, we can use their own egg by IVF, and by giving them extra support, they can have their own baby even. So that was a very interesting question in my MRCOG exam, because the patient came up with the AIS, and she was not getting convinced because she thought that she was a male. And then we convinced her by telling her, how about, she kept on saying that I'm a male and I cannot be a female, though I look like female from outside, but I'm a biology student, and how can I be a female? So we just convinced him that the genetics are not going to let her decide that whether she's going to be a male or female. It's just that how she looks like and how she wants to be. And there are some mothers we know with XY genotype who have a uterus. So would you call them male or female? And they are still having a baby. So this is how we still not able to understand that how some of the congenital adrenal, Mullerian problems can have uterus by partial inhibition of these AMH levels. Am I making your point clear, Eamon?
Yeah, doctor.
So is there any other questions, girls? So I think all of you have completely understood this topic. I've tried my best to make you know all small details which this topic involves to make you understand better to how so that you can handle these scenarios in a better way. If you have any queries regarding our course, please let us know. My team is at the moment online, and you can contact them. And we're starting our first session on 4th of June, this Sunday, and the course will be ended up in 2 months period of time, and we will be sharing all the guidelines, summaries, and all the questions, and at the end we'll have important recall session, and and then the support would be given till your exam. Thank you.